Hi, my name is Kevin O'Keefe, and welcome to Beyond the Numbers, where we go beyond CIHI data to the issues facing Canada's health systems. Each year, we release an immense amount of data with one goal: to improve the health of Canadians. But our data is only as good as the teams that use it, which brings us to today's topic: collective impact, a relatively new technique for groups of people to work together to try and solve big, complex social issues like poverty, education, and healthcare. To be honest, when I first heard about today's topic, I didn't understand exactly what it meant until I read an article from the Tamarack Institute, co-founded by one of today's panelists, Paul Bourne. It talked about a small county in Oregon whose goal was to eliminate teen pregnancy. In 10 years, they were able to reduce it by an astounding 75%. This, despite the fact that the groups working together had polar opposite views on how to prevent teen pregnancy. Health advocates wanted to promote safe sex, educators thought sexual literacy was the key, and faith-based groups said abstinence was the only way. So how did they do it? Collective impact. Quick shout out to people zooming in from right across Canada today, including Saskatchewan Medical Association, the Schizophrenia Society of Canada, and Nova Scotia Health. And now, on to a little housekeeping. All webinars in this series are available in both English and French. To listen in French, click on the globe icon. If you can't see the globe icon, click More. As well, closed captions are available by clicking the Show Caption button at the bottom of your screen. When you join today, you are automatically muted, but we really want this webinar to be as interactive as possible. There are a number of ways to do that. I have a list of questions here that some of you wrote in when you registered. Also, you can type a question in the Q&A button at the bottom of your screen. My colleague Angela from CIHI is standing by and will be reading off your questions throughout our discussion. We'd also love to hear from you directly. Just click the raise hand and my colleague Heather from CIHI will unmute you. You can also ask a question at any time. We really want this webinar to be interactive. And finally, this webinar is being recorded and will be available on the Beyond the Numbers page on cihi.ca, as well as in a follow-up email you'll be getting within a week. Before we begin, we acknowledge and respect the land on which CIHI offices are located. In Ottawa, it's the traditional unceded territory of the Algonquin Nation. The Toronto office is located on the traditional territories of the Wendat, the Anishinaabe Nation, the Haudenosaunee Confederacy, and the treaty lands and territory of the Mississaugas of the Credit. We acknowledge with respect the traditional territory of the Kanien'kehá:ka, where our Montreal office is located. In Victoria, we acknowledge with respect the traditional territory of the Songhees, the Esquimalt, and the Wasanich peoples, whose historic relationship with the land continue to this day. We recognize that these lands are home to many diverse First Nations, Inuit, and Métis peoples, and we embrace the opportunity to work more closely together. Now, everyone can feel free to acknowledge the land you are zooming in from in your own way. Just before you meet our panelists, it would be helpful for us to get a sense of what you know about today's topic by answering our poll. So, if you could take a minute and quickly tell us how much you know about collective impact. Absolutely nothing, a few things, I'm very knowledgeable, I regularly use collective impact in my work. Now, each panelist is just going to take a second and briefly introduce themselves and talk a bit about what they'll be sharing in today's webinar. I'll start with you, Vivek.
Thanks, Kevin. It's Vivek Goel, and I'm the President and Vice Chancellor at the University of Waterloo, and a public health physician, health services researcher. I most recently served as the chair of the board at CIHI and just stepped down last month. And I think I'm here because about 5 years ago, I was asked to chair an expert group charged with developing a pan-Canadian health data strategy. And Kim McGrail, who will introduce herself in a minute, was also part of that group. And one of our sort of starting points was to look back over 60 years worth of reports on what to do about health information and health data in Canada and why those recommendations hadn't been followed or why we failed to build the kind of health information system we would all like to have and that Canadians deserve. And there are many common themes, and there's a series of reports from our expert group that are up on the Public Health Agency Canada website. But one of the key sorts of observations was improving the state of health information requires many different actors to work together towards a common vision. And that's when we started to look at some of the work around collective impact. And you described one of the examples earlier, which are really about how communities come together to solve a common shared challenge or reach a common shared goal. And so that's really what was the basis for our recommendations, that really addressing the very significant issues, setting the right policy frameworks, getting people to come together on standards, getting people to come together on access issues requires players right across the system, certainly governments, health providers, healthcare organizations, professional or associations, as well as members of the public working together. So I'm looking forward to talking more about the learnings from collective impact and how it can help the health data ecosystem.
It sounds like an almost impossible task. But I think that's the nice thing about collective impact is it kind of breaks it down, and I'm sure we'll get into more of that, exactly how it works. But thank you for teeing that up. Speaking of teeing up, Kim, welcome. And can you just give us a brief description of who you are and what you'll be speaking about today?
It's great to be here. I'm Kim McGrail, and I've just started a new position as Associate Dean of Research at the School of Medicine at Simon Fraser University. But this comes after 30 years of work using routinely collected health and social services data for policy relevant research. I've always done that work in partnerships, but for the last few years have been CEO and Scientific Director of Health Data Research Network Canada. This network exists because CIHR, our funding agency for health research in Canada, recognized that even though we have great data and 50 years of experience using and leadership using these data from health and social systems for research, that largely those things were taking place, all of that research was taking place in single provinces and territories rather than multiple regions or multiple collections of those across the country. So we were funded to break down those barriers and support multi-regional research. In the work of our network, I think is by definition a collective space, because, and what I've come to understand is that some of the most important things we need to do, but some of the most complex, are working across groups and individuals and institutions and organizations. And so that's the collective work for collective impact. And the collective impact area that Paul will talk about more about provides at least some kind of method or guidance to do that work in a way that provides the best possibility of success. So it tackles the multi-regional space and also everything that Vivek described as well. So it's great to be here to have this conversation with you.
And that's so topical because that's, given what's happening in the US, all we keep hearing so much is about interprovincial cooperation, when it comes to beer and wine, but it'd be great if we could do that with health data as well. Leah, can you briefly introduce yourselves and get a sense of what we'll be hearing from you today?
Hi, everybody. It's a great honor to be here. My name is Leah Marie Stevenson. I am a caregiver advocate who has worked on policy changes to improve Canadian healthcare systems from user perspectives for 20 years now, with a 5-year stint in the Ontario healthcare system, working on behalf of community-governed, equity-focused primary healthcare teams. On top of working on better primary healthcare as the foundation of our healthcare systems, I've worked on topics like treatment access, equity, determinants of health, Indigenous self-determination, reconciliation, personal health data, interoperable health data, artificial intelligence, rural and remote health, community health infrastructure, and community health and social service integration, and really in the broadest sense of integration. How are the different parts of the system connecting better with each other? for the benefit of the people trying to have better health outcomes and for the benefit of the providers within that system and the system as a whole. I'm currently a consultant and have the great honor of being the strategic lead of a group called All-Can Canada. They're a national network focused on earlier and more equitable cancer diagnoses. I'll share more with you about them a little bit later on, but we're really trying to apply a bit of a more of a collective impact approach to that network. So due to the nature of the type of work I've been doing for the last 20 years, I've thought about and experimented a lot with the question, how do we do systems change work better? And collective impact has been a big part of the answer that I've found to date. And so I'm really looking forward to today's conversation. Thanks.
Excellent. Certainly, last but not least, Mr. Bourne, Paul, can you give us a brief summary of who you are and what you'll be speaking about today?
Well, Kevin, thanks so much for inviting me and for having me be part of this amazing panel. I'm with B Community. We're a large-scale change consultancy. Though I was the co-founder and CEO for 20 years at the Tamarack Institute. And we used collective impact to significantly reduce poverty. When we started working at poverty reduction, it was 17% in Canada. And when I left Tamarack, we were down at 7% in Canada. So it's an interesting take. Of course, we were one of many initiatives that were working to create that reduction. But there's a story behind why we found collective impact and why almost nothing else that we were doing worked. And that's an interesting one. And just to give you a hint, our organization won one of the 40 best practices in the world by the United Nations, even though poverty had gone up by 5% during the period for which they recognized us. So that's just an example of us doing amazing work and not achieving the outcome. So I want to talk about that a bit. I've recently published a book called Breakthrough Community Change, How Common Agendas Change Everything, which is a book about collective impact. And I've been fortunately supporting CIHI for several years in their pursuit of collective impact through their focus.
Excellent. So before we get into that, I just want to quickly go through the poll. Now that you know a bit about what we'll be speaking about today, according to our web poll, 43% know nothing about collective impact, 50% a few things, and then 6% are very knowledgeable, and only 3% regularly use it in their work. So lots of open minds to what we'll be sharing today. So Paul, I know you teased a few things there, but I want to jump back into you before we open it up to Q&A. I Googled you, and according to Google, you are a collective impact pioneer. So that's why I wanted to kick things off with you. Let's start with just why someone would want to use collective impact. Why do you think this is a solution to somebody's challenges?
Well, going back to that story, here we are, an agency that wins one of the 40 best practices in the world. And I get up to accept the award. There's about 300 people in the audience. And I say, like, this is kind of weird. Like, the problem got worse and we're considered the best. And somehow that doesn't resonate with me. And that's when we decided that we needed a whole different approach and we needed to bring everyone together. I loved your example, Kevin, of the group in Oregon around teenage pregnancy. We don't have to agree even on the what, but in a sense, we have to agree on the why, the how, right? And to work together. And that all of our methodologies, right? All of our belief systems can work in tandem toward this common agenda, which in that case was to end teen pregnancy. So that's why I think collective impact is what I consider the most advanced form of collaboration that we know. But it is part of the collaborative structure. So we're attracted to it because most of us understand the value of collaboration. But this is what's interesting. Most collaboration is process heavy and outcome light. Collective impact is collective, so it's process heavy, but it's impact, which means that it's outcome heavy. We don't collaborate just to learn from one another. I mean, the word just is probably inappropriate there, but we want to have this outcomes focus. We want to have a specific impact. And in some ways, that's the common agenda. What we've observed, and Tamarack was one of the observers that formed the language, one of those observed to form the language for collective impact. But there are 5 steps really to a collective impact process.
Yeah, how exactly does it work?
Well, I mean, first of all, we want to bring large scale collaboration. We want to bring people from all kinds of sectors to the work. And so when we're saying that we want to have a better health outcome, we're not just looking to bring people who are from the health sector, specifically working in the health sector, however broadly we define that. We want the private sector involved. We want government involved. We want people with lived and living experience. I'm so glad Leah is here today, right? People who advocate for change from a user perspective. And so we want all of those in conversation, learning and agreeing on a path forward. Then we start to look at what we call shared measurement. How are we going to know that we're making progress and then working toward agreeing on that? We then form what we call roundtables that are what are doing what we call mutually reinforcing activities, meaning that we're trying to work as multi-sector as possible. So we frame the activities we're undertaking in ways that everyone can contribute. Continuous communication is the 4th one, and it's critical because to keep a big system moving and engaged, we need to be talking with them. And lastly, and maybe the most importantly, innovation that collective impact has brought is the backbone structure. The backbone structure means that there is a deliberate system of actors that are supporting the collective to keep them engaged, to keep them working together, to keep them advancing toward their goal. Maybe most importantly, that the common agenda, I think, is one of the most important pieces. But the key in a common agenda is collective impact. Collective impact, for the most part, has us looking at, first of all, large-scale buy-in from many sectors, buy-in from an entire community. And secondly, it most often leads to a population level change. And this is very important in health. Maybe I've learned more about population level change, particularly from evaluators in health, than any other sector. So it's something close to our hearts.
I promised that this would be as interactive as possible, and I see we have our first question, so I'm going to ask Heather to unmute Rebecca. Rebecca, go ahead with your question for Paul.
Hi, Paul. Thanks, Kevin.
Hey.
Just given that you're looking at large, complex problems with lots of like different players, organizations, I'm assuming this kind of thing takes a long time, like probably years. How do you stay motivated? What keeps you going? And do you ever get discouraged?
Yeah, most people say I'm an annoying optimist, so that could be a problem.
Let's get the real story, Paul.
Of course, we are discouraged at times, but like the work is that's why I wrote Breakthrough Community Change, because I wanted to show the method as it progresses. And if we use the collective impact properly, there is a lot of work to do. And we see a lot of progress as we move forward. And even the way that we evaluate change. I mean, first of all, we're looking at a change in that real people have better outcomes. So that's one of the changes. But then the second one is, are we learning as a collective? And in turn, because we're learning, things are getting better. right? We're actually performing at a higher level. The
So
third
even though you haven't achieved your final goal, you can
Yeah.
see incremental improvements along the way that keep you motivated?
Absolutely. And the third one,
Okay.
we often look at policy level changes. Are
Hmm.
people working differently? Not just at the government level, but through systems and maybe hospitals and health systems. Because once we start to see those types of changes, then we know that we have
Mm.
the large scale change beginning to occur. I think the key is like this idea of continuous communication. I like to think of it as continuous engagement. And I can give you many examples. My favorite is Des Moines, Iowa, that every year they met every quarter. The entire system met every quarter, 2, 3, 400 people in the room. But once a year, they met for a day and they had a party. And it was an interesting party. It was a data party because the data would come from the state that would help them understand how they were doing. In the US, they had an interesting way of doing this. And the newspapers were there, the donors were there, everyone was there. And it was an incredible celebration of their work. And of course, they at that point were extremely successful and averaged around 25,000 positive outcomes per year.
Wow.
So, that's why when I say it was a party, there was a number of standing ovations at each one of those meetings, and then many of the projects that were undertaken. Collective impact in itself is extremely stimulating. And for the most part, when it's working well,
Mhm.
people will say, I've never been involved in anything like this before.
Wow.
And it's I've often found it challenging to get people to have turnover on the working committees and boards because people are just so engaged.
I want to open it up. You teed it off perfectly for our panelists because they've been using this specifically in healthcare issues. And I wonder if we can ask each of you to talk a bit about how you've used collective impact to tackle some of the big, complex topics that you mentioned at the beginning of the webinar. Let's start with you, Kim. Can you talk a bit about how you use collective impact in some of the work that you're doing?
Sure. I mean, I hinted at this a little bit in my introduction. So just to give you a sense of things, I'll talk about this from the standpoint of Health Data Research Network Canada. We are a network of about 25 different organizations across the country. And I think what I would like to do in saying how we go about our work is just pick up on a few things that Paul has noted. So first of all, we're all in organizations that are either supporting access to data or using health data for research, work with researchers, or have roles that are somehow related to that. But there's a lot of diversity in our network. Some of us are, like CIHI itself is a member of our network. So some of these are pan-Canadian organizations. Some of them are provincial. Some of them are brand new. Some of them have a 35-year history. Some are highly embedded with Indigenous organizations and have a strong public outreach. Others are newer to that. So there's this big diversity. And we're not, as Paul kind of intimated, we're not trying to make everybody the same in building this network. One of the things that I've learned about networks over time is that you need to honor the diversity of the network while keeping the focus on that common vision that Paul was talking about. So this is how you can actually build this. And I'm using network kind of interchangeably with the large collaboration, although Paul would probably would talk about this a little bit differently if we're talking beyond institutions and organizations and so on. So a second thing that's really, really key to this is relationships. And Paul kind of hinted at that, but this is in that party kind of atmosphere, right? Because the way that we get things done really is by building trust, which comes from knowing people and having that common view and understanding that you're different, but you do have an objective that you're all working towards together. And then the relationships just make everything else easier and faster to get done over time. And I think the other key thing is we all have to recognize that we're working together because we're actually trying to as Paul said, we have this common objective of some sort. So we're trying to shift the status quo in some way. And really, in the end, this has to be about thinking about systemic change, not individual actor change, but something in the structures and systems where we are trying to address that needs to be different if we're going to have the outcome that we want. So those are all very challenging things. Systemic change always means a shift in power dynamics or somebody giving up something so somebody else can have more. I mean, there are cases, of course, where when we all can gain from things, but in a lot of cases, we actually just need to admit that something isn't working fundamentally and we need to do something differently. And I'm going to just close with a quote that I read from a woman named Karen Pittman. And it really kind of speaks to this systemic thing. We're not trying to get individuals to do things differently. We're trying to get systems to do differently. And what she said is programmatic interventions help people beat the odds, while systemic interventions help change the odds for people. And I think that shift is a really important one if we're thinking about collective impact and how we do things. So that's what I would add right now.
Really helpful. Before I get to the other panelists, I know Angela have a couple questions. I just thought why don't we go to the questions as well, and then we'll keep moving along through the panelists. Go ahead, Angela.
Thanks, Kevin. Paul, there's one specific for you. Can you share with us some ways to measure collective impact beyond the basic way of counting number of partnership meetings, number of partners, etc.?
We work at this in a variety of different ways, and sometimes we just use traditional evaluation methodology, though it doesn't work that well. We do look at fairly traditional ways to understand, are people having better lives? We try to figure that one out. Number two, as I had said earlier, we look at what are we learning and how are we learning together. And it's part of what Kim was saying, and when she was quoting Karen Pittman, is the system getting smarter, right? Are we thinking about things differently? And we monitor and measure that. And sometimes we do that through surveys. Sometimes we do that through focus groups. And we look for concrete changes that are occurring because of the learning. And that takes us to the third one, is that we start to monitor systems change. It's actually easier than we thought to get that. I mean, sometimes we have to actually monitor a vote. Sometimes it's a self-declared systems change where an organization will tell us that they've changed something for their clients, whoever that might be. And so that's kind of what we're looking at for the most part, is we're working at those three broad levels. Process evaluation is interesting. We do some of that, but then there are varieties of evaluation types. And I'm not going to go into those into any detail, but I know that formative and summative evaluations are only somewhat helpful. And we have adopted much more of a developmental evaluation. A fabulous book by Michael Quinn-Patton. Mark Cabage is someone we use an awful lot. He's probably the foremost expert in developmental evaluation in Canada, and has a lot of free stuff that you can learn about that. But a developmental evaluator joins with you through the process of your collective impact initiative and is helping you with continuous feedback loops. Those are then documented and quantified.
Great. And I know you mentioned as well that, you're getting those kind of quantifiers throughout the process. So it's not just a big party at the end. You can see the progress throughout. Vivek, do you want to expand a bit more on what you mentioned at the beginning of your talk in terms of how you use collective impact directly in your work?
Sure. And, maybe I'll start by noting that, in health, whether we're talking about population health and improving the health of the entire populations or the delivery of health services, we're always expecting multiple individuals and organizations to come together. So if we think of health promotion, The Ottawa Charter for Health Promotion, which goes back now, I guess almost 40 years, was all about communities working together to improve their health. If we think of all the different restructuring that happens over and over again in our health systems across the country, regionalization, local health integration networks, family health teams, we're always trying to move pieces together so they work better together. And one of my observations is rather than doing it with structures, let's use things like collective impact models, because we'll keep rearranging the deck chairs of the health system if we don't figure out how to get people to work together. And so the concept of having a common agenda, common vision, everyone's talked about that already. So in the Pan-Canadian Health Data Strategy, we recommended adoption of a common vision and a common health data charter. And at the highest level, that's essential because, as we know, in Canada, it's not one health system. It is a series of provincial territorial health systems, as well as Indigenous, First Nations, Inuit, Métis people's health and health for the military and so on. So we have a collection of health systems. And so we recommended across the collective, we need to have agreement on a common vision. And that was in the form of a health data charter. And you can imagine what it's like working in the federal, provincial, territorial space, trying to get ministers of health or first ministers to come to agreement. But, amazingly, we did get back in October of 2023, adoption by the ministers of health of a Pan-Canadian Health Data Charter. There's a footnote in there. Quebec did not agree to sign on, but the footnote says Quebec shares the values of the charter and will work in its own way to achieve them. So, that's the reality of the Canadian Federation. But that's an example of how at that highest level, you get agreement on a common vision. But obviously to do it in a space like health data, it's more than just getting the ministers of health to agree. It's all the other players across the different levels of the health system, public, private sector actors, not-for-profits, as well as the individuals who are accessing and receiving health services. And so, I think we're on the start of a journey here. It's going to take quite a bit more work. I think the final thing I'll just say, and I think this is a bit of the experiment we're now engaged in here with this activity. Most of the examples, and if we think in the population health area, health promotion, or the examples around poverty reduction, which you could say is a determinant of health as well, that Paul talked about, are at the community level. So a community is coming together. And when we're trying to do something at a pan-Canadian level, it's about getting a whole bunch of communities to work together. And I think that's a relatively sort of new challenge for applying collective impact. I know it's been done in a number of other domains, but in health, I don't think we've had much experience in trying to get all the communities in the country to come together at the same time.
And just a quick plug, you talk a bit more about that. You did a podcast for us recently. So anybody who wants to hear a bit more about what you've been speaking out can listen to the podcast where Avis Favreau and you talked a little bit more about that. And I'm sure we'll talk a bit more about it today. But Leah, I quickly want to get to you before we go to more questions. How have you used collective impact specifically in your work?
Right. I'm going to share just a couple of slides just
Yeah,
so that
please.
because pictures can tell 1,000 words and I can say a lot fewer of them. As mentioned at the outset, I'm Leah, and I have the great pleasure of acting as the strategic lead of AllCan Canada, which is a national network inspired by collective impact that encourages earlier and more equitable cancer diagnoses. So AllCan Canada, we have been constantly working in a multi-stakeholder fashion, trying to bring more and more of the the ecosystem together. And that ecosystem, for whatever the key challenge in healthcare that you're trying to, or opportunity that you're trying to address, that stakeholder mapping is really important. Who are all the key players that are a part of the problem and of the solution, right? For the given issue that you would like to understand and work on together. So we've been working in that multi-stakeholder way and growing that stakeholder group, and I'll talk a bit more about who's on it at the end from the outset. So from that perspective of sort of bringing the collective together, we started out with some mixed methods research because we wanted to understand the problems and the opportunities together. So really that level setting as a group. So we did some mixed methods research to understand, as it relates to earlier, more equitable cancer diagnoses, what is the current state? What is the future state? Where should we be heading? And we made sure that this mixed methods research was not only drawing from the literature and from provider perspectives, but was very deeply embedded in patient and caregiver perspectives as well. And so, we developed a few key materials to really kind of try to summarize what we learned. And these patient experience maps, the one I'm sharing here is the current state of cancer diagnosis in Canada. So what things look like now. So these, we also developed a future state map, and we've been developing practice case studies. And we're doing this to try to help unleash the mutually reinforcing activities within the broader ecosystem. So both like those who are participating as part of our network, but also everyone we're meeting with and engaging with and sharing what we're learning with the broader ecosystem who maybe aren't formal members of All Can Canada. And so these patient experience maps and the practice case studies provide, actually these patient maps in particular provide a summarizing infographic, basically, of today's inefficiencies in cancer diagnosis from the point of symptom to treatment plan. And this is the future state infographic. They also try to provide a picture of what a better future looks like, and from the meso level, so, primary care teams and diagnostic assessment programs or rapid investigation clinics if you're in Quebec and that sort of thing, pathology, all of that good stuff, right? So what does that better future look like, and how are they all connecting? From that level of meso to the macro, so what needs to happen within the system when it comes to data, when it comes to funding and infrastructure, when it comes to health and human resources, all the way out to more of the mythos levels of the system. But really those pieces in the blue around the edge, it's more like, what are the signs of health within the system, and what are the supportive pieces at that sort of systemic level that would really be flourishing if all the rest of the system is working in a healthy way. And co-design being the cross-cutting and a key part of collective impact, really, that makes all of this possible. So this is just from our website. We've been developing practice case studies, which are spotlighting evidence-based Canadian practices that improve earlier, more equitable cancer diagnoses from what we've been learning. And so basically all of the findings from our research, combined with we're now into our second of our 3-year strategic plans, which we make sure that our strategic plans remain anchored in those research findings. They form our common agenda for the members of our network to guide and encourage those mutually reinforcing activities that we were chatting about, where you want to be able to do your own job better. You don't want to be doing other people's job. And you want to make sure that you're connecting in and knowing who all the other players are that your sector or your organization needs to be in relationship with, so you can achieve those better health and population health and system outcomes that we're looking for. So really to help encourage, this is the common agenda, to encourage the mutually reinforcing activities, as well as to encourage the mutually reinforcing activities, as I mentioned earlier, amongst the broader ecosystem that are involved in cancer diagnosis, who aren't necessarily, participating on our network yet. We use key performance indicators to help us with our shared measurement. And we use a collaborative governance approach with, as I said, as much of a diverse and adaptive ecosystem membership as really being key to supporting that co-ownership of the issues and the solutions. And as well as this really allows us to deploy as much meaningful, continuous communication as possible. This type of governance, collaborative governance approach helps unleash that collective seeing and the collective learning and the collective framing. We have a multi-stakeholder steering committee who is the strategic level. And then there's three, at the moment, this has changed over time, three multi-stakeholder working groups that are focused on priority projects. And it's their own little collective impact initiatives. And then that very all-important backbone support, which is provided by a secretariat. And just to give some examples of some of the tactics for continuous communication, absolutely, there's elements of it that are engagement and co-ownership. So like there's various grades to how this is happening depending on who the audiences are. And then there's just like outright communication, where you're maybe trying to communicate out to people who aren't part of your membership and bring more people on board and really encouraging that broader impact. So we use tactics, none of which would be too surprising to anyone, different audiences in the ecosystem, quarterly internal and external newsletters, social media. We've got a new website, which has got all the key resources available to people in the practice case studies, stakeholder correspondence, stakeholder meetings, conference presentations, workshops are even better because we can be co-learning with the people and bringing more people on board to our collective impact initiative through those workshops. We have lots of room to grow in terms of the ecosystem and the relationships with relevant providers, jurisdictions, deepening First Nation, Inuit, Métis relationships. Sectors like emergency medicine we have not engaged with yet, but they're vital to the work. At more provinces and territories where we haven't built relationships yet. The backbone support for the network is provided by an incredible patient organization called Save Your Skin Foundation. And so as the strategic lead, I work with Save Your Skin Foundation. They're the group that hires me and my colleagues to provide that backbone support to the network. And just lastly, All Can Canada, because if you Google us, you're going to see that we're globally linked. We're a national initiative of a European network called All Can that focuses on efficiency in cancer care across the whole care continuum. So that's our website and how you can reach me. And I look forward to today's conversation.
Terrific. Clearly, you've struck a chord because I see the Q&A button tallying up there as you're presenting. And thank you for giving just a great example of how you can take the collective impact principles and kind of apply them to a case study like that. I'll go over to Angela now. She's got a bunch of questions for our panelists. Go ahead, Angela.
Thanks, Kevin. Okay, panelists, how do we avoid the potential dangers of being mired down in process again in collective impact? Given that collective impact brings together different sectors and encourages collaboration, how do we ensure the process is streamlined and effective?
And you guys are all on the screen, so you can take turns, or whoever wants to kick it off.
I'll start off and then pass it to our experts in collective impact. We are mired down in process. I think that's what I would just say in health, right? No matter what we try to do, we are mired down in process. I think what this is about is creating a systematic approach to make the process more effective. And so, I'll pass it to Paul and Leah maybe to talk about some of their experiences there. Kim.
Yeah, for sure. I mean, Paul's definitely the expert here, but I have some quick thoughts I have is part of it. There's many things here, but one thing that the importance of strong backbone support is huge, right? Because you need that dedicated expertise and resource. Doesn't have to be big, doesn't have to be a lot, but who are really making sure that those 5 conditions that Paul was talking about, the convening towards defining that common agenda, or the mutually reinforcing activities, the communication, the continuous communication, the backbone support is really important to doing that and making sure that things are hitting that not too hot, not too cold, right? Not meeting just for their own sake, but meeting because there are key milestones and key discussions and dialogue and learning and relationship building that needs to happen along the way. So I think backbone support is really important. I would also encourage just to the earlier conversations and questions around outcomes, evaluation, and how do we know whether we're doing things well, et cetera. It's complex work. To build on all of the really great suggestions being made there, I'll make sure that these are resources that get shared out with everybody. But there's a collective impact evaluation and performance framework, 3 sort of guides in there, which brings together a lot of what Paul was sharing. And I think it's just really important because it really helps frame for you the fact that this is long-term work, to be done in a rigorous fashion, and our expectations of what we're able to achieve as we go along the way will change over time, and the outcomes that we're measuring will change over time. And so in the earlier part of putting something like this together, it is more process oriented. You're looking at more process oriented outcomes, but it's things like, do we have the right players? Do we have the right structures to be working together? Are we working at the right pace, or are we mired down in process that's useless? Are we, anyways. And then as you get into sort of the mid period of after doing more of this organizing, getting to know each other, understanding the problems together, forming a common agenda. Do we have a common agenda? I mean, that's its own process outcome for the first little beginnings of a collective impact initiative. When you get to the middle part, then you can start seeing some more outcomes that might be related to behavior change or whatever the case may be. And over the longer term is where you would start to see, hopefully, those improved health outcomes, population health outcomes, and all that good stuff, right? So I would say part of not getting mired in process is being very clear about it takes time, and you can expect different types of success at different points along the continuum. And you want to have a good understanding and sort of framework around that. And you want to have really good support working with you to make sure that you're doing this in a way that is not getting mired, but also not losing the rigor and just jumping to like, okay, let's try and like fix these really, really complex problems really quickly without doing the hard work of, do we have the right people? Are we working in a healthy way together? Do we know what we're trying to achieve? Do we understand the problems, et cetera, et cetera? So all of those steps along the way,
We just have about 10 minutes left, and I know we have a couple more questions. So, Paul, you can hold your thought, but I just want to go to your next question, Angela, quickly.
Yes, thanks. How do we apply the concept of collective impact to the increasing issues patients are facing related to social determinants of health?
I want to start by just helping us see that collective impact is helpful and it's not definitive. So we don't need to use collective impact the right way, right? We can just learn about it. And that's, a matter of fact, the most important thing that I share with most groups. Spend a year learning about collective impact, bringing diverse actors together in your community or within your system, and learn about it. Because it's going to make you ask all kinds of questions. It's not only an ambition. It will make all of your work better, because I deeply believe the most important thing we can do about understanding collective impact it actually is the most advanced understanding we have around collaboration. Now, social determinants of health are broad, but it's important because one of the key learnings in collective impact is involving people with lived and living experience. And so we bring people in who are living the challenges that we are trying to support them in or solve. And we understand that when people with lived and living experience are deeply involved, and for us, we just had a simple formula that at least 25% of those in any of our working groups or leadership roundtables needed to be people with lived and living experience. Even if it slowed down the process at the beginning, it brought a kind of authenticity to the conversation that was extremely refreshing to people. And guess what? Going back to the previous question, people with lived and living experience have little patience with process, as do business leaders that we often bring in as well. So that's one of the ways of actually dealing with it. But yeah, it's extremely important that we are working at the level of practice, not just theory here, and that we're working on real issues that improve people's lives. I could now go into individual social determinants of health, because I think we've worked at almost all of them in different ways at different campaigns. but it's a very important question, and I think it was an important way of describing this idea of bringing in people with lived and living experience.
Go ahead, Vivek.
Yeah, I was just going to add in on Paul's points that I think the other thing that this question really flags is that when we get to an issue like this, it's not just now collective impact work across the health system, but it's bringing health system actors together with other social services, other community agencies. And so, one of the areas where I think we have lots of examples is around homelessness and health. Many areas communities across the country have worked on how do you support homeless people as they come into emergency rooms. And that requires work, obviously, with housing, but police services, ambulance services, social services, mental health services. You got to bring many different actors together around that shared vision.
Kim, do you want to add anything?
Yeah, just really briefly, I mean, to everything that everybody's already said, I completely agree, and think that the question is super important because for all of the things that we're talking about, it is those structural and social determinants of health that create part of the system that needs to be changed. It's things that have been ignored, or it's the fact that in health systems we still tend to think about individual choice and individual responsibility as being a major part of the solution to any issues, as opposed to the system itself needing to be changed. And I think we all recognize that health systems are still very institution organized and institution focused. And this is kind of a way to help move away from that. The other really quick thing I just wanted to add in sort of relates to the previous question, which is I think it's important to acknowledge that the long-term ambition for collective impact almost, I think by definition, means it's not necessarily what we would call the most efficient way of getting something done, but it will be the way that has a lasting change effect. And it is a way to bring people around to, as Vivek was talking about, the sort of North Star of something like the Health Data Charter. If we kind of keep drifting off, but reorienting ourselves to those broader goals, and we're going to actually be able to get where we want to over the longer term.
North Star is a good analogy. Angela, you had another question there?
There is, yes. What are the common challenges for the Backbone Support Organization?
I mean, one common challenge is annual funding cycles. I mean, long-term collective impact is longer-term work, and so that can be challenging when you're dealing with annual funding cycles. I would say is certainly one challenge.
Well, often the backbone organizations fall into the problem of hubris, and they think that they're far more important than they are. The common agenda is really the backbone. It's not the staff that are running it, and that's kind of a difference here. This is to support the collaborative to be working well together, to not get bogged down into process. The backbone supports the collective. It doesn't lead it. That's really an important distinction and understanding. And when they think they're leading it, or they think they know the best way forward, then we have almost always problems. The other one is that they have a sense that they are convincing. There's a lot of kind of marketing and whatever. They try to convince people that this is the right way rather than working at an engagement level where we're engaging people, we're drawing them in. And that often takes, a lot of one-on-ones, a lot of small groups. And it's about building those relationships. The work will get done. It's the interesting thing is that when you have a collective effort, work gets done differently. It's not linear in the same way. Often what we'll find is people working together, nothing feels like it's happening, and all of a sudden this massive change happens. And people are going, how did that happen? Right? And then they look back and they see the patterns and the track. And a good backbone structure, for those of you who don't know, it's often a staffed structure that is there to ensure that The different working groups are working well together. They're supporting these high-end leaders to work together, with everything from minutes and so forth. But they're also working behind the scenes and implementing some of the work that the working groups are thinking through.
We have a couple minutes left, and we got a few comments people wrote in when they registered. I'm just going to go to Dean wrote, would love to see a hybrid of beyond the data approach with collective impact, especially as it pertains to public health, which is often hampered by the lack of compelling data to demonstrate its effectiveness to decision makers. Does anyone have any thoughts on that comment in terms of the challenges of getting effective data with the collective impact model?
I do think that, yes, prevention, it's so invaluable, but, oh, yeah, it's hard to tell in numbers, right? But, and I mean, I think the more and more the system is able to invest on that side of the care continuum, and the less and less sort of flare-ups we see it further down the continuum, that will probably become more and more of a good problem to have. But one thing I would say is that certainly, I think when it comes to data and collective impact, valuing not just sort of the quantitative, but also the qualitative and people's stories and lived experience, and summarizing that qualitative is an important piece. So it's definitely not discounted. And I think in the context of things like prevention and public health and et cetera, I think that could be a really important part of how one tells the story of the success of certain types of initiatives.
It's a really important question, and obviously, given the time, maybe we could have another webinar on this topic.
Yes,
The whole genesis of the Pan-Canadian Health Data Strategy was, from the early days of COVID, where it became clear we didn't have the data we needed to manage this immense public health emergency. And it's not, I think, as this question is really getting at, it's, we don't have that data because we haven't really invested that in the systems we need for public health, population health data. I know as CIHI, as part of its transformation work, is actually working on developing a core set of indicators for public health, which will be the first time, I think, across Canada that we work for something like that. So I think there's going to be lots to come in this area.
Well, perfect way to wrap up. I really want to thank our panelists for a terrific discussion today. And of course, everyone who came out, especially those who asked questions. A quick note, we welcome any feedback to today's webinar. The easiest way to reach us is at beyondthenumbers@cihi.ca. Also, this week, you'll be receiving an email from us with a survey about this webinar. Please take a minute to fill it out. That email will also have links to resources that our panelists discuss here. I know there was lots of mentions about a book and various things. There'll also be a recording of today's webinar and a registration link for our next webinar. So we'll be taking the summer off, but we'll be back on Tuesday, September 23rd to talk health data economics and the wealth of information that we're sitting on in Canada, literally. Did you know that we have some of the richest health data in the world? But every year, we leave almost $10 billion on the table because of missed opportunities to use our data better, not to mention all the benefits to patients. Please sign up today. We'd love to have you. Thanks again, folks, and see you on September 23rd.